Okay, good evening, everyone. My name is Cassandra Taylor, and I'm the founder of Top Flight Defense Incorporated. And this evening we have Dr. Judy Dubyel. Did I say it right?
My first name's Ruth.
Ruth, did I say W?
You
I'm
said
sorry.
Judy.
Judy, I'm sorry. Forgive
So
me,
it's
Ruth.
Ruth Dubyel. You did pretty good on the last name.
Dubyel. Okay, Dubyel. And she is an assistant professor in obstetrics and gynecology department at Rush University Medical Center. We both work at the same facility or same hospital, just in different departments. And she's here to do a class on PCOS. So, Ruth, tell us about yourself and tell us, what is PCOS?
All right. Well, I am like Cassandra said, I'm an assistant professor of obstetrics and gynecology at Rush. I've been at Rush for 4.5 years. I am a military brat, so I grew up in the military, and I appreciate all of the service that all of our veterans give our country. I actually focus a lot of my time just in kind of general care of women. So I do take care of a lot of patients who have PCOS. And that is what we're going to be talking about today, talking about exactly what PCOS is, what the symptoms are, and kind of how, as a physician, I help women manage their symptoms that come with PCOS. As I am going through what I'm talking about today, please feel free to ask questions. There's always, in these Zoom meetings, there's always that chat function. You can try to do that. And I'm going to ask Cassandra to alert me if she sees any questions coming through on the chat.
I could do that.
And then at the end, I will kind of have a little slide that says, hey, what questions do you have now? So we'll have a little question and answer period at the end of as I'm talking. But please feel free to interrupt me if there's something in the moment where you're like, I don't understand, clarify, or whatever. All right, so let's jump right into it. What is PCOS? PCOS stands for Polycystic Ovarian Syndrome. It is a combination of at least two of these following symptoms. Excess androgens, and androgens are what we call male hormones. So basically testosterone, as most people think of it. There is another male hormone that's called DHEA. We don't use that quite so much in the diagnosis of PCOS, but it comes up sometimes as people are reading and learning about it. These excess androgens cause symptoms like acne. And this is typically something that we're talking about in adults. Some adults just have acne because they're blessed with that sort of skin, but it's not typical for adults to have acne. So if a woman has these excess androgens in her system that are causing acne, then one of the options that we look to about what could be going on in her body is PCOS. These excess androgens can also cause what we call hirsutism, which is excess growth of core. So this is typically a lot of hair in areas that we don't think of women having a lot of coarse hair. So some women have really thick sideburns. Some women will have thick hair along their chin and their neck. Some women will have extra hair on their chest or on their belly. This isn't to be confused with, most of us have like that one coarse hair that will pull off our sideburns, or like a couple like mustachy type hairs, or a couple hairs on chins that will pluck. This is a lot of excess hair in those areas. One of the other things that we're looking for are irregular or infrequent periods. So most people who have PCOS will often go 3, 4, or 5 months without getting a period. Another one of the symptoms is polycystic ovaries, which could also lead to enlarged ovaries. Polycystic basically means a cyst is kind of like a little bubble that forms in the ovary. In several slides, I have a good kind of picture to kind of show what I'm talking about when we're talking about cysts in the ovary. But anytime you hear someone say a cyst, it's just a fluid-filled bubble. Women who have PCOS have a lot of these little cysts throughout their ovary that then makes their ovary bigger than we'd expect it to be. PCOS affects about 3 to 7% of the United States population. Some estimates say it's as high as 20%. So that's 1 in 5 women in the United States is affected by PCOS. It also causes frustrating symptoms. Other than the acne and excess hair, it can be difficult for women with PCOS to get pregnant. Some of them also experience extra pelvic pain that can be associated with their periods or even in between periods. They can also experience weight gain, fatigue, thinning of their hair, darkening of their skin, mood changes, and sleep problems. So this can cause a lot of disruptive symptoms. One thing that I always try to focus on with people is what PCOS is not. It is not a disease that can be cured. The symptoms of PCOS can be managed, and most people who have PCOS are able to live pretty regular lives and manage their symptoms, whether it's acne or extra hair or fertility problems or pain. I am a little bit of a obstetric and gynecology nerd, and I really like learning the history of things, and particularly for PCOS in Chicago is kind of the history of the people who studied it and kind of brought it into the mainstream, if you will. When PCOS was first something that we were learning about, it was known as Stein-Leventhal syndrome. Stein and Leventhal are two physicians, Irving Freeler Stein and Michael Leventhal, who worked at Michael Reese Hospital here in Chicago in the 20s and 30s, 1920s, 1930s. They were actually studying the causes of infertility in women. During their studies, the treatment that they were proponents of doing a procedure called an ovarian web resection, which kind of started out as a way for them to get a biopsy of the ovary and examine the structure of it and see if the structure of the ovaries was impacting women's ability to get pregnant. But what they found is that in these women that had Stein-Leventhal syndrome, the web resection of the ovary actually restored regular periods in about 95% of the patients. So as they were studying this and publishing their paper in the early 1930s, everything that they were talking about was, hey, the way to treat this is to do a surgery on a woman and take out this little, when I say web resection, it basically means they take out a little wedge of the ovary. So if this is the ovary, they just kind of do a little triangle cut into the ovary and remove that tissue. So they said that treating with hormonal treatments like birth control didn't work. There also wasn't very effective birth control around in the 1930s. So the best option they had was to do this ovarian web resection to kind of shock the ovary into working a little bit better. You'll understand that a little bit more as we talk about some of the following slides. So this is a slide that I was kind of referencing before to show pictures of what the cysts on the ovaries look like. This ovary ultrasound, if you've never looked at ultrasound images before, these are ultrasound images. They always look, they're kind of fuzzy and cloudy, and you have to kind of use your imagination as you're looking at it. But as you look at it, this little area that I'm tracing with the arrow is a normal looking ovary. These little black areas are cysts or follicles. These are normal. You have 1, 2, 3, 4, 5 little cysts on this ovary. That's a normal number of cysts. This is a normal sized ovary, nothing concerning there. This over here is the ovary of a woman who has PCOS. You can see how the ovary itself is a lot bigger, and there's something along the lines of like 13 visible follicles or cysts in this ovary. So this is polycystic, this is normal. So some of the other conditions that come along with PCOS are infertility. The infertility that comes with PCOS is really because women who have PCOS don't have regular periods. If you don't have regular periods, it's difficult to tell when you're ovulating. And if you can't tell when you're ovulating, you can't kind of figure out the best time to have sex to help you get pregnant. Insulin resistance is also a factor that women have when they have PCOS. This is because they tend to have higher body fat, which can make them resistant to the effects of insulin, which makes them more prone to develop things like diabetes. They often kind of struggle with obesity. We don't really know the connection to all these associated conditions, but a lot of women who have PCOS gain weight easily and struggle to lose weight. So a lot of these women do things that try to help them lose weight that work in their peers that don't work for them. Women with PCOS are at risk for getting elevated cholesterol, especially as they get older. Like I talked before, it's easy to gain weight. These women also tend to struggle with fatigue and being excess tired all the time. They can notice thinning hair. They can notice darkening of their skin. They can notice mood changes and headaches. Now, the mood changes, again, we don't really know why these last 4 or 5 things happen. They just are things that have been found to be more common in women with PCOS than women who don't have PCOS. Women with PCOS can also have sleep problems. It tends to be not necessarily problems falling asleep, but problems kind of staying asleep and being able to sleep through the night. All right. I think to understand PCOS and what's happening with it, it's important to understand the normal function of the ovaries. This diagram kind of gives just a drawing of this is this is vagina right here, cervix leading into the body of the uterus. You got tubes on either side that kind of hang out right near the ovaries on the side. Again, this is kind of a drawing to show you, hey, this is a normal ovary. This is a polycystic ovary that's bigger and has multiple little follicles or cysts in it. The main function of the ovary is to secrete hormones. And these are the hormones that we typically think of for female hormones like estrogen and progesterone. They also produce a small amount of androstenedione, which is more of one of those androgenic hormones that we talked about earlier, like testosterone. To give some background, a fetus that's developing in the uterus during pregnancy, at 7 months of pregnancy, a fetus has approximately 7 million eggs in their ovaries. By the time that baby is born, there are only between 2 and 4 million eggs. This amount is depleted by about 90% by the time they hit puberty. So by age 37, they're down to only 25,000 eggs. By age 50, only 1,000 eggs. And then you go through menopause.
Oh.
This, I think, is really important to understand because women do not make more eggs as they move through life. You're actually constantly, your egg supply is constantly depleting. And then this little statement that just kind of showed up here is talking about how an egg develops into something that's going to be released from the ovary during ovulation. So it starts out as what we call a primordial follicle, which is just this small little bubble sitting in the ovary that has an egg inside it. Then it kind of develops into a primary follicle and then becomes an antral follicle. There's only one antral follicle per menstrual cycle, but there can probably be up to like 6 or 7 primordial follicles. The way I think about this when I'm kind of thinking about this process is that you have all these eggs that are kind of next in line, and 6 or 7 of them are like, okay, it's my turn next. And so they're waiting for the body to like choose them. So I think of this cartoon of little eggs standing in line being like, pick me, I want to be next. The one that's chosen is the one that becomes the antral follicle, which is then the one that's released when ovulation happens. In a typical woman that does not have PCOS, this process is driven by some glands that sit underneath the brain called the hypothalamus and the pituitary glands. These glands secrete hormones that are called gonadotropins that communicate with the ovary and tell them, hey, it's time to ovulate. Kind of like I referenced before, talking about the depletion of eggs through time, it's important to remember that throughout a woman's reproductive life, only about 400 follicles ever complete the process of becoming antral follicles. All of the other eggs that are in the body undergo a programmed cell death. So they kind of die. That's what happens to all those other eggs that are disappearing by the time we hit the age 50. I included this little picture in here because this is a little bit of what I think of in my head when these eggs are waiting to get picked, standing in the line, pick me, like this little minion here. Going back to kind of the gland of the hypothalamus and the pituitary. So here is this little image with your brain. Your hypothalamus sits kind of like right in here, and then the pituitary gland is right next to it. That's all kind of in this little base part of the brain. So the hypothalamus produces this hormone called gonadotropin releasing hormone that communicates with the pituitary, tells the pituitary gland to release these hormones called LH and FSH, and then communicate with the ovaries and drives them to release their hormones. And then these hormones kind of give some feedback to the other glands to help control what's going on. This is what drives ovulation. Ovulation is what drives the period. So once the ovaries ovulate, if there is not a pregnancy 2 weeks later, you have a period. If you don't ovulate, you're not going to get a period. So for whatever reason, oh, here we go. I'm talking about this a little bit here. Typically, when someone in the medical field is talking about the menstrual cycle, we're thinking that the way we think, like the terms that we think about around the menstrual cycle, is that day 1 of a period is day 1 of your cycle. And then day 1 of the next period is the beginning of a cycle. So let's say someone has their first period today, which is, I should know the date today, September 22nd. That's day 1 of their cycle. Let's say they have 7 days of bleeding, and then 3 weeks later, they start a period again. So I think that would fall sometime around October 20th or something. So that would be a 29-day cycle. That doesn't mean they bled for 29 days. That means that from the first day of one period to the first day of the next period, that's their menstrual cycle length. The average duration of a menstrual cycle is 28 days plus or minus 7 days. So the range of a normal menstrual cycle length is between 21 and 35 days. If you think about this, most people think about a regular period in terms of like month to month, keeping in mind that our months are not all the same number of days. So, and then also most of our months are 30 to 31 days. So if you get a period every 28 days, it's not always going to be on the 5th of the month. It could be on the 5th of the month, and then the 3rd of the month, and then the end of that same month. That's still a regular period if it's happening every 30 days or every 28 days or whatever it is. There are 2 phases to the menstrual cycle. There's the follicular phase and there's the luteal phase. So the follicular phase goes from the first day of your period to the day that you ovulate. The luteal phase goes from the day that you ovulate to the day that you start your next period. In the vast majority of women, the luteal phase is 14 days. So you ovulate, 2 weeks later, if you're not pregnant, you have a period. This luteal phase tends to get shorter after you pass the age of 40. So women tend to have periods that feel like they're a little bit more frequent as they get older. So there you have it. This little graphic here talks about how there are different ways to diagnose polycystic ovarian syndrome. There's kind of different guidelines on how to follow. Or how to say, hey, I think you have PCOS. One of them is from the National Institutes of Health. Their 2 things that they're looking for are hyperandrogenism. So that's the sign of excess androgen, like acne or hirsutism, which is the extra hair growth. And oligomenorrhea means infrequent periods. So according to the NIH, if you have acne and 4 periods a year, you've got PCOS. The most common one that we use in the medical field is called the Rotterdam criteria. For this one, you need 2 of either of these 3 things: the hyperandrogenism, the oligomenorrhea, or the polycystic ovaries. The way we would tell if someone has polycystic ovaries is by doing an ultrasound. Going back to those images that I showed you before, we'd be looking for some of those findings on an ultrasound. So if you have acne and we do an ultrasound and have an ovary or 2 that look like they're polycystic, you have PCOS. The other one to use is this Androgen Excess and PCOS Society guidelines. They say that to get the diagnosis, you need to have hyperandrogenism, so acne or extra hair, plus either irregular periods or polycystic ovaries. So all of them use the same symptoms, but kind of a different combination of them to make the diagnosis. I think what's important is that just because someone has infrequent periods doesn't mean they have PCOS. There can be other things at work. Just because someone has acne as an adult doesn't mean they have PCOS. They could just have acne as an adult. If they're having regular periods and there's no signs that they have polycystic ovaries, it's just acne. So going back to why women who have PCOS have irregular periods, it's because in this kind of diagram that I showed you before of this hypothalamic pituitary ovarian axis, the excess androgens interfere with the release of gonadotropins. So what happens is the testosterone or the DHEA that is circulating in higher amounts in women who have PCOS kind of comes over here and cuts this communication or disrupts this communication. So the hypothalamus is releasing less of this GnRH to communicate to the pituitary, to communicate to the ovaries. All right, before we move on to how we treat the symptoms of PCOS, are there any questions right now that someone wants to get answered before we move on? Oh, I see a bunch of,
I don't see any questions in the
I don't
chat.
see any questions either. Okay, great. So talking about how we treat these symptoms of PCOS. Starting with the irregular menses. The most common way to address irregular periods is combined hormonal birth control. So these are things like birth control pills, which most people have heard about. That's why I have the picture up here of it. You take a pill at about the same time every day. These packs are made to give you a period every 28 days. There's 3 weeks of pills that have hormones in them, 1 week of pills that has no hormones. You're supposed to have a period during this week of no hormones. This works because these hormones are tricking your body into thinking that your ovaries are releasing them. And then when you have this week of pills that has no hormones in them, it mimics a drop in hormones that typically triggers a period. So you're taking the pills, you have hormones in the body that seem to be mimicking what your body naturally was supposed to be doing. And you take a week of pills that have no sugar or that have no hormones in them and have a period. The patch and the vaginal insert ring act in a similar way. They give you hormones that are supposed to kind of imitate what the ovaries are supposed to be doing so that you get a regular period each month. The hormonal birth control suppresses the secretion of that luteinizing hormone. It also suppresses the release of androstenedione, which is one of those androgen hormones that the ovary releases. It also increases sex hormone binding globulin. Sex hormone binding globulin kind of scoops up extra testosterone in the body. So if the birth control causes there to be more of this sex hormone binding globulin, there'll be less of that testosterone circulating around to cause the disruption of that communication process. While it doesn't work quite as well and it's not approved to be used for this purpose, some people find that using insulin sensitizing agents, such as a medicine called metformin, helps their period become more regular. We don't really understand why this happens, but for some women with PCOS, when they start taking metformin after several months, they will notice that their periods become much more regular. So that's kind of one of those, if you've ever heard anyone say this is an off-label use for the medication, it's because the FDA hasn't approved it for that specific purpose. Metformin overall is a pretty safe medication, so that's why some people opt to use this instead of being on hormonal birth control. It decreases the excess androgen, so it kind of helps decrease those circulating levels of testosterone. the way to reduce the risks of getting high cholesterol and kind of and developing diabetes as life goes on is really lifestyle modification. So increasing the amount of exercise that someone's doing, making some dietary changes, and doing your best to achieve weight loss. Now, if you remember before, I said that one of the characteristics of women who have PCOS is that they gain weight easily and it's hard to lose weight. So weight loss can be a big struggle. The method of weight loss that seems to work the best for women with PCOS is simple calorie restriction. It's always a balance of what goes in and what you put out. And so kind of trying to stick to a somewhat strict calorie balance is what works the best to help women with PCOS lose weight. There is not a proven specific diet plan to follow. There are some foods that seem to help balance some of the hormonal differences for women with PCOS. Those are things like having diet that's high in leafy greens like spinach and kale, avoiding foods that may kind of convert to things such as estrogen in the body, which are things like soy. So kind of minimizing soy in the diet. And then just exercising. Most of us in America don't exercise enough anyway, so we could all use a little bit more exercise. And then one other thing to use that can reduce the risk of cardiovascular disease and diabetes is metformin. Metformin is actually a medicine that is used to treat diabetes in general. So if we use it at low doses in women who have PCOS, we're decreasing their risk of developing diabetes later in life. The way that we address fertility issues for women with PCOS is lifestyle modification. As I referenced before, for many people, weight loss can help the body resume regular ovulation patterns. So if they're able to lose even like 10% of their body weight, their periods may become more regular. If their periods are more regular, they can figure out when they're ovulating and capture that moment, that kind of window of ovulation, to be able to target their sexual encounters to try to get pregnant. If that does not work, there are some medicines that we can use to kind of manipulate the body into ovulating when we know it's going to happen. The most common medication used for this purpose is clomiphene citrate. It's also known as Clomid. And the other one is called letrozole. Letrozole is not FDA approved for this specific purpose, so it's an off-label use, but it has been actually found to be more successful at helping ovulation in women with PCOS than the Clomid has been. Both of these medicines we have to be careful about using because it does increase the occurrence of multiple gestations, basically twins. People who use Clomid or letrozole to help them get pregnant have a higher rate of getting pregnant with twins. If those two medicines fail, there's a group of medicines called gonadotropins that are kind of the next step. Typically, gonadotropins are used, they're injectable, and they're used with the oversight of a fertility specialist. Regular OB-GYNs, general OB-GYNs like me, most of us are perfectly comfortable helping women use Clomid and letrozole to help them get pregnant. And then if those medications aren't working, we can go to a procedure called ovarian drilling, which is not done very often because honestly, Clomid and letrozole are very successful. And if they're not, the gonadotropins are very successful. Ovarian drilling is similar to the ovarian wedge resection I talked about before when I was talking about the history of PCOS. Basically, ovarian drilling is a laparoscopic surgery where we kind of make little incisions in the belly, get some instruments inside the belly with a camera showing us what we're doing. And we take a little kind of electrocautery or a little laser and kind of laser several different parts in the ovary. And that kind of, the goal of that is to try to achieve the same thing as that wedge resection was doing in the 1930s with Dr. Stein and Leventhal. I personally have never had to resort to ovarian drilling for a patient, but I do know some colleagues that have done it before. The benefit to doing it is that if doing that helps someone achieve regular periods again, they don't have any increased risk of getting pregnant with twins. However, the long-term effects on the ovaries aren't clear, meaning if we are burning part of the ovary to try to stimulate it to work better now, we don't know if it makes them go through menopause any earlier than they were supposed to go through menopause, if we've disrupted how well that ovary is working in the moment. As far as treating the extra hair growth, this is not as easy a thing to treat. Birth control actually works pretty well to help minimize the extra hair growth, especially if it is combined with a medicine called spironolactone. The reason the birth control works, I didn't write this down on the slide, but the reason the birth control works for this purpose is, again, it increases the sex hormone binding globulin. If it increases that, that kind of pulls the testosterone out of the system. So we're kind of secondarily decreasing the amount of extra testosterone in the system. We can also use a class of medicine called anti-androgens. These are not approved for the use of treating the extra hair growth, and there aren't any really strong studies that have looked at how well this works. These medicines can cause harm to a male fetus. So that's what that medical term is, teratogenic. It basically means that if a woman is taking it during pregnancy, it can impact how the baby grows and develops and can cause some malformations. So if someone is using an anti-androgen, they need to be on birth control. Spironolactone is another option. So it can be used on its own, or it can be used in combination with birth control pills. The full effect of using this for extra hair growth can take up to 6 months. Interestingly enough, spironolactone may cause menstrual irregularities in about 20% of the people that use it. So I think this is interesting because we're using it to treat the excess hair growth in women who have PCOS, many of whom have irregular periods. Then we're going to give them a medicine that might give them irregular periods. Another medicine that can be used is called Flutamide. The main reason this is not used much is because the side effects are almost as annoying as the extra hair itself. It can cause very dry skin, and it can cause hepatitis, which is basically damage to the liver. Or there is topical eflornithine. This one, again, isn't used as much, but it is available. It's topical, so you basically apply it to the areas where the extra hair is growing, and it could take up to 6 months to see any effect from using it. I think it is very important to point out that the reason we've talked about all this today is because September is PCOS Awareness Month. For anyone who is interested in learning more about PCOS or kind of having contact with a group of people that know, that are experiencing it or living with it, the PCOS Association of America has an excellent website. They also have had a recent social media campaign for PCOS Awareness Month called the Faces of Pcos, using the hashtag Team Teal, because teal is the color for PCOS awareness. And then I also think it's important to point out that there's a lot of celebrities who have been diagnosed with PCOS who are living their glorious, glamorous, successful lives. So these are people like actress Lea Michele from Glee, Jillian Michaels, sorry for my typo there, the fitness personality, and then Daisy Ridley, who is the Star Wars actress, Victoria Beckham, and Harnaam Kaur. I think for anyone who doesn't know who Harnaam Kaur is, Google her, because she basically has a full beard. So she is a very extreme case of the hirsutism that women experience with PCOS. But she's also very proud about her body in its natural state, which is why she's become a personality that people know. All right, that has been a lot of information. I feel like I breezed through some of that stuff. Oh, and then someone in the chat pointed out that Kiki Palmer has also been diagnosed with PCOS. Thank you for pointing that out. Are there any questions that anyone has thought of right now or wants clarification on? Feel free to unmute yourself and speak up if you'd like.
Hi, my name is Deanna. I do have a question.
Okay.
My daughter is 23. She has autism. She's high functioning, but she's not at the stage where she would be comfortable with any kind of exam
Okay.
or ultrasound. I suspect PCOS, but I don't know if that's the case because she doesn't have the irregular cycle. She does have the hair. She has everything else except for that.
Do you
Uh,
think that
mhm.
she would be able to tolerate an ultrasound over her belly?
No, only because of the water, having to fill the bladder. That part.
So that makes it a little bit trickier to figure out for sure if she has that diagnosis. But she very well might. And even if she doesn't, the things that we do to help control the symptoms of PCOS can be helpful for her also.